I'll shock you. The most important tool when you're going to consent a patient is your eyes. If somebody rings you up in the middle of the night and says, "Sir, I've got a problem, I've got this patient," and they reel off a load of symptoms, would you rather be by the bedside and see the patient yourself and take an impression, what's going on? Or would you rather take the information over the phone and deal with it that way? What is the best way to deal with a sick patient, or any patient indeed? To see them. So when you see the patient, what information would you get from that patient? When you see somebody for the first time, that'll give you an impression how anxious they are, their body position, how they understand what's going on. It gives you an idea, a concept, and the exchange of information between you and that patient then enables you to do what? Get a relationship, trust. When you are going to invade somebody's body, and that's what you're doing, and I'm emphasizing that, you are encroaching into that person's most personal space. You are assaulting that person. What they need to do is have trust in you that you are going to do the best you can. So consent isn't just about a process. Consent is using this. Consent is using this. Consent is using this. The last tool you use is this. You listen to what they have to say. Has anyone ever said that to you before? It's new. So we are now consented the patient. Patient's on the bed. Patient's got a cannula. How much sedation would you give? Would you sedate every patient?
How much sedation do you give in colonoscopy? That's the question. No, how much? And what do you use?
How much? Okay. Okay, so that's the practical way you're delivering it. But how much would you give a patient of midazolam in milligrams per procedure for a colonoscopy? 3 to 5. Okay.
And what else do you give? Sorry.
Yeah, no worries. I was going to ask the same.
Pins, how much? 1 to 4 cc. No, but
Ooh.
you need to tell me in milligrams. I don't understand 1 to 4 cc. 4 milligrams. You give 1 to 4. And so we can ask the same question.
Yeah.
And you use sedation. So how much sedation did you give? How much? Average 3 to 5. And pins or tramadol or pins, how much? Let me just say this. So 3 to 5 milligrams of midazolam, and you would either use tramadol or kins, and that would also be about 2.5 to 5 milligram. Yeah, and sometimes you use NOSPA. Okay, right? You know what
NOSPA?
is? I won't tell you. I'll tell you in a bit. It's like bowel paralyzer or
Buscopan.
It's not hyoscine actually.
Yeah.
NOSPA is not hyoscine. NOSPA is supposedly, it works like hyoscine. There are a lot of people use it. We don't use it. But okay, there's nothing wrong. I don't know why you use it. We'll discuss that. So, Doctor?
I'm not giving sedation in every colonoscopy.
You're not giving sedation?
No, in every colonoscopy we don't give. For children, we give 2.5 milligram of midazolam. And for some adults, not in every colonoscopy, 2.5 to 5 milligram of midazolam.
Okay.
So
Children?
You said, sorry.
I was going to ask children.
So children, what are you talking about? Age group?
Age group, I am not doing colonoscopies in children below 8 to 10 years.
So you're talking about 10 to
15 years.
10 to 15.
15 years.
10 to 15, you do it under sedation.
Under sedation.
And whether they are girls or boys, both.
Both.
Okay. And that sedation would be, do you give more sedation to children or do you give the same amount?
Like half of the dose of
Half of
the dose of the adults.
Doctor, how much do you?
I haven't started yet the colonoscopy.
So you're not.
Yeah. So for flexible sigmoidoscopy, usually patient don't need any sedation.
No. This is my.
Okay.
This is the team from. Just quickly, if we can introduce them. Yeah. Omar, you start and then you can pass on to the rest.
Assalamu alaikum everyone. I'm Dr. Omar. I'm a GI resident at Patel Hospital, year 2. And next. Yes, I've started doing colonoscopy. It's like 9 months now, and successfully sometimes a few if I'm lucky, but usually I'm not able to go to the cecum.
Assalamu alaikum. My name is Dr. Mehreen Sial, and I'm a GI resident at Ziauddin Hospital, Clifton campus, year 3.
Assalamu alaikum. My name is Dr. Muhammad Ali Kadir. I'm working as a registrar in the Department of Gastroenterology Hepatology at Dr. Ziauddin Hospital, Clifton.
Hello, Assalamu alaikum. I'm Shamim Nazir, GI resident, R2 at Ziauddin Hospital, Karachi.
Okay. Excellent. Just to be
Assalamu
clear, if
alaikum.
I was going to endoscope a child of any age, I would be actually looking for a GA, because I don't want a child to be remember anything at all. And I was introduced to a new idea when I came to this country, and I actually went back to my country, and I agree. So any young ladies under in this country 20, and to you it may be a large age, I would be also very easily convinced that a GA would be required in that instance. So for dignity and for privacy and for a lot of other reasons. And so I thoroughly respect that, and I learnt a lot. So it's like you come to an area where, and I say an area, I don't say a different country, you come to an area where you have to think and you're introduced to new ideas. I went back to the UK and I said what I learnt. So in coming to this course, I learn. And that's what Sada said, that's what Sajid said, we learn. So we learn from you. So what I'm saying to you is that's what I would do. Okay, so on this course, if we have anybody under a certain age, don't be surprised if we say to you, you know, what would you do in this, what do you think about? Well, that's a hint to say, oh, that's a good idea, I think that's what we should be doing. Okay, with regard to sedation, I tend to do a lot less sedation than what you give. Okay, you at the moment we're talking about colonoscopy. So sedation itself actually carries a high risk. Sedation itself is most risky when? Is it during the procedure? When you give it? When's the most risk you get from sedation? That is something to add to the issue, but when is the patient most at risk from your sedation? Sorry? Well, no.
What he's trying to find out is, when you give him the sedation, what is the time when the patient is under the maximum risk? Like immediately when you give, is that the time when they're under maximum
Yes.
risk, or during the
Hands up who
procedure
thinks it's, hands up who, when you've given it straight away. Hands up.
जिसमें फौरन अगर किसी को दे दिया, उस वक्त कोई रिस्क होता है मरीज को? Is it risky? Is it most risky when you just give it? You think it's most risky when you
So
give
you,
it?
okay. Is it risky? Is the most risk when they've got it and during the procedure?
When the peak plasma concentration of the drug is achieved, that is the time when there is maximum.
So when's that?
When is that?
Yes.
When is that? When would there be the peak plasma concentration?
It depends upon the half-life of the drug.
We know the half.
Which one you're giving me? He's asking you midazolam. what's the
Midazolam.
half-life?
So it is during the procedure.
During? Anybody? Anybody want to be controversial? Well, I'll be controversial. It's after the procedure. Most complications with sedation occur after the procedure. Why? No one's got a tube up the bum. They're not being stimulated. So when you actually are now relaxing, and then the drug has actually still taken effect because of the half-life, that's when you're most at risk. That's when you need a high-class recovery area. That's what is now in this institute. So what you've got to be aware of is you may be giving 5 milligrams. That's a big dose, by the way. You know, I agree when you're on a training course we will be giving a little bit more than what we would normally give, but 5 milligrams is a large dose. If I was to say to you 78% of my colonoscopies that I've done lifetime is no sedation, no pethidine. And that's not a brag, it's true, that's just because of the way it is. And I would actually say that Pakistanis, particularly the elderly men, are more stoical, they put up with more. If I got a young buck, as I would call him in England, 6'6", muscles out here, he'll be screaming with your 5 milligrams and your pethidine. He would be screaming. It's the way it is in the UK. Yeah.
So this is where when we started the courses, realized I have a different approach to it, and we discussed this. Our cultural differences. So that's why I asked this question: Are you using sedation in girls as well? So when it comes to ladies, we are a very different society. Okay, even sometimes men also, but this is a very, like Paul just said, you're intruding into someone's, real personal. When it comes to girls, in our practice, pediatrics is always under anesthesia. I don't do it under sedation. No child is done. I have said no child, almost no child is done without sedation. Now, 15-year-old boy who looks big, and we explain and he's okay with it, no problem. But generally children, this is a traumatic experience, especially for girls. So because of our cultural differences, I don't do it. Secondly, my sedation, if I was to divide, my sedation is more in women and less in men. Okay, so you remember the best thing about midazolam is the transient amnesia. And that's what really is needed. Otherwise, for colonoscopy, except relaxation, midazolam and KINs are not going to do anything. That is why if you have a bad look, no matter how much KINs you give the patients, right? So in the last 4 years, things have changed. Since COVID, things have changed drastically. We started doing everything under protocol. All our GIs, upper, lower, everything was done under propofol during COVID. Mainly upper to 100% because we didn't want any, we never stopped in COVID. So entire 4 years, our endoscopy never stopped in COVID. But now we need to go back to the way things were. But this is the difference we have, and the reason and rationale is that.
So sedation is a risk. So when you're actually taking your consent, how many of you tell the patient what the risk from sedation is? Are you just quoting the fact of possible perforation, possible bleeding? But do you ever discuss the risk from sedation? No. So it's something that if you actually look at the complications in the UK, most complications are second to sedation. Sedation has been the prime instigator of the issue. So I would say to you, when you look at your practice, start consenting with regards to risk to sedation. You've got suppression of your breathing, you've got suppression of the way they're thinking, and most importantly, the amnesic effect can actually cause a few complaints, which has happened in the UK, has gone to the GMC, and the doctor was finally vindicated, where a patient accused him of sexual assault because she couldn't remember her knickers being taken off after sedation. And worst of all, she says, being put back on. Now, as luck as it was, there was 2 nurses who actually had assisted her at the time to get dressed, and that was all documented. But that still was dragged out for 2 years, and that doctor still was pulled in front of the GMC. That's how far it got. So what I'm saying to you is there are risks with sedation, not just to you from how the amnesia, but the risk to the patient from the sedation, the breathing issues, the cardiac issues, everything that comes with it. Right. So when we have a patient in the room, what do we do to ensure their safety? Monitor. So that pulse oximeter in front of you, how good is that pulse oximeter? Not 100%. So how long does it take for that pulse oximeter to register a change in a patient? Straight away? 10 seconds? Seconds. 60 seconds it takes. So 60 seconds a patient is before it actually gets fully understood by the machine. And what it's doing is it's measuring changes. Those changes are happening. It's measuring the through here, the reflection through the finger, and the amount of light that's put through, and that's what it's doing. It's measuring that, and it's measuring that as a percentage. That percentage, already the heart is actually having a compromise. Already the breathing is relaxed. So we've already got the issue going on. This is still pumping around, and we're still registering no problem. 60 seconds later we have a problem here, but this is still having an issue, the breathing, the heart. So what in endoscopy is your greatest tool? Not your pulse oximeter. What in endoscopy is your greatest tool, your greatest aid? Sorry? Supplemental oxygen. We give that will come to that.
I don't know if the capnograph can help us in this setting, because that actually measures the exhaled carbon dioxide.
So you're talking another machine?
Yes, when we are doing that, we can't rely on one pulsometer, so we can maybe see the capnographic reading, number one. Number two is I think we can see the respiratory rate and heart rate, the other vitals that may reflect the ongoing cardiac pressure or hypoxemia. And the last.
So we're still relying on the machine.
We are still relying on the machine. The other thing is that we need to ensure that we should have a reversal agent, just in case if that is
You've
required.
jumped a step.
We have jumped a step. So the clinical parameters, maybe I think the clinical examination, the respiratory rate, I think that could be one of the things.
Right, these are actual things. So I can look at a patient and I'll go, his blood pressure is now 115/20. I can look at a patient and say his pulse is 500. I'm being facetious, because the most important aid in your room, there are three things. One, your assistant, your tech guy will be actually with that patient looking. They will see any changes. The patient may be talking or maybe flinching. They've stopped flinching. They've stopped moving. The tech guy, the nurse, is the first warning that there's something going on. Soon as that person stops talking to the patient, unless you're one of these people who say, don't talk to the patient, keep them quiet, which I think is very poor. I think they should be talking and supporting the patient wherever possible. But soon as I hear that conversation or a change in tone or anything, I stop and I look. So the most important aid in your room is your tech guy, your nurses. The next aid is your ears, and the next one is your eyes. not your pulse oximeter. As I said to you, in the middle of the night, someone could turn around to you and say the vitals are this, but would you not have preferred to have seen the patient yourself? Walked in, that patient is comfortable. So you may have a low blood pressure, you may have a high pulse, but the patient's comfortable. What could be going on? And you don't see that. You need to see it, you need to hear it. So in an endoscopy room, in my opinion, we often discount and we often belittle the support that these guys can give. It's not about you and the procedure. It's not about you getting that scope from A to B. Forget it. It's the whole process, and the person who will help you the most, one is the patient. That's the person who will help you the most. The next person who will help you the most is the tech guy and the nurse. The problem in all of the process is yourself, because you lose focus. You get so focused on passing this scope. You need to focus. You need to listen to the tech guy. They will bring you down to earth. If you ask, is the patient okay? You will hear me all the time. How are they feeling? How are they? Is everything okay? Yes. And then sometimes I'll say, are you sure? Then they'll look at you and you say, oh, I'm sure. I like it because what happens is that when you get a good relationship with them, they will actually turn around to you and say, Paul, I don't need to hear anything else. As soon as I hear the name, I'll stop. Whatever you're doing, you'll hear your name. Stop. So we've gone from consent, and I've asked you to look at the patient, listen to the patient. We've now got into the room, and we've looked at the procedure. We've talked about sedation, but the most important thing there is looking at the patient, listening to the patient, and listening to the environment, what's going on. Not relying just on the equipment. That's not having a go at you, but the equipment is an assistant. It's an aid. It is not definitive. If I was to take you into that room now, genuinely, put a pulse oximeter probe, Nelcor probe, get the wire that's coming from the machine and put it across, it will give you a reading. That's how accurate they are. They are an assistant. They're advisory. Don't rely on them. Okay? So now we're progressing with the procedure. Patient's uncomfortable. Patient starts going, what do you do? Stop. Stop. So do we all wait till they go, Smile on your face, or probably. The thing is that when you're actually advancing the scope, you can start feeling the scope tightening up. You can feel a little bit of resistance. This is about looping. When you feel that, it isn't about continuing with the scope. What it's about is thinking, why are they going? So the question that I ask you now is, what is the question you should do when you sense it is getting a little bit difficult? What are you doing? What should you do? What is the first thing you should do when you find that the procedure as you're progressing is getting difficult? You are now trying to avoid pushing the scope. So I'm saying pushing because that's what happens when you're causing pain. You are pushing, you're not passing. So when you're pushing the scope, what is the most important thing you should do?
I think you should start de-looping the patient.
Pull back. Okay, we've got pull back.
We need to see if we have any loop, and we need to de-loop it.
We need to see if we've got to loop and de-loop it.
Yes.
So you've jumped a couple of steps ahead. No worries. Change the position. Change the position. What should we do before we change position? What should we do before we pull back?
Oh, so take the air out.
Now it's like driving in the snow. I'm driving now, my wipers are working. Snow comes down, I switch the wipers off. That's what suction does. I switch the wipers off, the snow goes on the screen. So now I can't see. Stop! Stop! So it's getting difficult. We stop. What should we do next? Just relax the scope. Brilliant. How are you feeling? Tell me what that felt like. That gives you an impression of what's going on. Okay, I can see where I want to go. I now would then genuinely, slowly. So, what is the most important thing? What you want or how you want it? Do you understand what I'm saying? What is the most important thing? What you want or how you want it? Do you understand what I'm asking? What is it's Christmas. Somebody gives you a present for Christmas. What's the most important thing? Is it the present itself or is it how it's given? Oh, I give you all my love with this flower. Is the flower now important? So, what is the most important thing? What you want or how you want it? The present. That's not an option. Right. If I was to say to you, withdraw slowly, what have you done? You've already withdrawn. If I was to say to you, slowly withdraw, what would you do? You'd do it differently. So what I'm actually saying, how you want it is more important than what you want. So any action in colonoscopy, we do it slowly. And why do we do it slowly? You've been very quiet. Now I start picking on people. Why would we do any procedure, any movement in endoscopy? I'm not giving you a get-out clause, but I'm not doing colonoscopy. Slowly.
I think that's the way.
No, I'm asking this chap.
Oh,
Just one
sorry.
sec. I will come back to you. Okay, so you're minimizing your risk by doing it slowly. You can anticipate if things are going safely. So when we're actually looking at slowly means safety. You're trying to support safety. If that scope continues to feel that it's getting tight, but the patient now is less uncomfortable because you're doing it slowly, so you're stretching the bowel slower. You're not doing this, you're now doing this. Is that still meaning it's safe to proceed? I've got a no. You don't know? Now we're doing the procedure slowly because of the safety reasons. And that's what we should do. Any procedure in colonoscopy should be done slowly so we can anticipate any issues that arise. So what we would do is saying how we want it done is more important than what we actually want. Yes? He's looking at you, Sajda, to explain. I can cause discomfort and have a straight scope.
What he's saying that you can have discomfort with a straight scope as well. So it doesn't mean that if it's not going in smoothly, you can have pain with a straight scope.
Some patients have spastic volume and they are sensitive.
So is now the patient at fault? So now it's the patient at fault. I'm very argumentative. Hello, I'm Paul. Right. So what I would be suggesting at this point And you will say, but sir, I can continue. I can see where I want to go. And I'll be going, stop. So now we're getting now to the teaching point before we move on from this point. You will hear us say, stop. Stop. Now you suddenly got, ooh, right? Stop. It's not an offensive word in colonoscopy. It's not an offensive word in any endoscopy. It's a safety word. So when I say stop, that means freeze. It means just stop. I want you to look at your hands. Stop. I don't want you to go, because the learning point has gone. I want you to look at how you stood. Your hands, I'll show you shortly on the mannequins what I'm talking about your hands. But if you stop, you'll learn more than if you go, yes.
So for like stop means freeze. Whichever posture you are in, you have to maintain that so that you can go back and get that work done.
Okay. So we're advancing the scope. Things are feeling a bit tight. We're advancing and the patient still got discomfort and it's increasing. We say stop. Your posture's fine. What should we consider? She ain't going to tell you the answer. We know you're okay. What do you think could be going on? We've started the procedure. The patient's lying there. They're just tensing up a little as you advance the scope. What are your options? And when you give me your answer, why? Okay. No, that are okay. So you've done two big things in one. Change of position, I agree. Why?
Because there are some points like the splenic flexure, the transverse colon and the hepatic flexure, where changing of the position can help a lot.
Okay. If I was to say to you, there is a large group of people now who start in the left lateral. As soon as they put the scope in the bottom, they turn the patient onto the right-hand side, and then they continue with the scope until they get into the distal descending. Then they put the patient on the back, go to the splenic flexure, then bring the patient up onto the right-hand side, advance the scope another 10 centimetres, withdraw, put the patient on the back, continue, put the patient on the left-hand side, advance the scope another 5 centimetres, withdraw, put the patient on the back, advance the scope down, and then get to the terminal ileum. That's what you've read. Garbage. So what I'm saying to you is that when you put the patient on the back, the difficulty isn't in your thinking of open up loops. The problem is that you've overinsufflated. A lot of people, when they're doing the procedure, this finger hovers over the air. When you actually pass the scope in, the scope is going down and coming up. What does air do when you put it into a closed system? It goes down and it goes up. It will fill the proximal colon before it will actually open up the distal colon. Putting the patient on the back, waiting a few moments, doesn't have to be long, drawing the scope back allows the air then to freely come back. You can then slowly suck down. Don't suck down one continuous suck. If you suck down one continuous suck, you won't actually give the patient relief. You'll think you have, but you haven't. So you just suck down and it actually allows it to come down. And after you've done that, you draw back the scope. In colonoscopy, what happens? This is the scope. You're advancing the scope. This is where you want to get to. This is all the bowel. You don't see it. You're advancing, you're getting closer, you're getting closer, you're getting closer. You get to it. But now you stretch the bowel. So you should then just let the scope come back, and then it comes back, and then the bowel sits forward. That's what happens. There's a little shimmy. Then you can continue with the scope. But it will always take a bit of the bowel with it. It's got resistance along the end of the scope as you go along. In Pakistan, you use lignocaine on the scope, very good, but it actually also dries out very quickly on the outside of the scope. So you do need to actually keep adding and adding and adding. KY jelly is what you use in the UK, and they very rarely use Instilla gel or lignocaine gel on the anus, very rarely. So, but what I'm saying to you is, because you use it here, just remember it dries out very, very quickly. How many people use a wipe holding the scope? Wipe, wipe, hold a wipe, 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 wipe. How many people don't use a wipe? Colonoscopy. So you've just said you use a wipe. But sometimes it's that you use a wipe. Who never uses a wipe? You can scope without using a wipe. Okay? So I tend to be able to advance the scopes a little bit further, and I'll show you why when we work on the mannequin. Okay? It's just slightly different. It is very confusing when you first see it at first. You think, oh right, it's just this. It's not. There's a lot that comes into it. So I need you not to be quiet. I need you to ask questions. If you don't ask questions, and it's not meant to be rude, you'll remain ignorant. My view do you know how I genuinely, before I touched the scope, I spent 3 months, I could have touched the scope before, but when I was learning way back when, 1986, 87. So where did for 3 months I watched. 3 months I stood this side, stood that side, stood this side. Where didn't have cameras, where was the best view I got? But I'm seen as something of a maverick. I'm seen as something that's a little bit strange. What I did, I got a table, and the endoscopist is here, and I stood on the table, and I stood up here, and I was watching what he was doing. He didn't mind, so I stood on the table, and I was looking straight down what he was doing, and I did that for a week. Now, because you've got cameras, you don't need to do that now. You can do a lot of things. I was watching the hands. These guys were saying just do this, but they were doing things that they didn't know they were doing. Okay? You're doing things because you're being shown how to do it. The things that we're going to show you is going to bring you into the idea of knowing what you're doing and why you're doing it. And if you know what you're doing and why you're doing it, it brings you back to what we're talking about right at the beginning. It's safety. It makes you safer. If you listen to what we're saying, which is when we say stop, we're asking you to say stop for a reason. One, you could be causing that patient avoiding a potential risk, and two, we could actually then be having a learning point of what we need to get you to improve. So anybody on these courses, regardless where you're starting, not done any colonoscopy, regardless if you've done everything and you think you're doing 100%, the end of the day, we're not going to belittle you, but we're going to look at your technique and we're going to say, have you thought of this? Now, if you think you know everything, you wouldn't be here. You don't know everything, and we don't know everything, so we learn from you as well. We learn from each other. So when you come on here, we're looking to actually support you and help you. We're looking to impart ideas and concepts to how to actually make you better at what you're doing. It never was offered to us, and that's the big thing. Now people are willing to share, people are willing to show. You're not going to see anything by a demonstration. You'll see, oh wow, that's all right. But what you need to see in real life is how it actually works for me. So the most important things, shall we recap? Sedation is the highest risk point. Then we've got a risk point of perforation. If you perforate with the tip of the scope, you're a barbarian. People can perforate. The most common perforations are with the loops. The tip is here, but your loop keeps growing. And I'll show you when we demonstrate outside the patient what the scope is actually doing. Okay? I'm getting excited, so I'm speaking quickly. Endoscopy excites me. It really does. I like it. So when I get excited, I get carried away. So even in this forum, ask me to slow down and stop, because I will. It's not a problem. I'd rather you do it. And what are you actually doing when you ask me to slow down and stop? What do you actually do? Because you're thinking like a colonoscopist. Slow down, stop. Okay? But what else are you doing? You ask me, you're actually taking ownership of your own learning, your own development. You're not being spoon-fed. I can't stand it when people say, give me my training, and they think it's in a cardboard box and they walk away with it. Take ownership. This is what I need, and can you help me with that? That's going back to your aims and objectives. My aims and objectives enables me to understand what my needs are. Okay? I'll give you a clue. I'm a bit difficult. So whatever you've written for your aims and objectives, they will be too broad. You know what I'm saying when I say they're too broad? Your aim may be to get into the terminal ileum, but there may be something else going on. Where if you build a tower, a high-rise block, but you want to live on the penthouse suite, if it hasn't got a basement, you haven't got a penthouse suite. So it may be something else that's preventing you living in the penthouse suite. You see what I'm trying to say? So we've looked at safety. The biggest risk points for patients is sedation. I'm not going to go through anything else. The occasional use of Buscopan. I understand why some people are using the hyoscines and all this type of stuff because of mucus and glare back from the scope and all this type of palaver. Not an issue. Okay, but that's used for more different procedures. When you're talking about EMRs, ESDs and these type of things, that's when I would consider using them. The use of Buscopan on withdrawal. The issue that I have with Buscopan, yes, it does relax the colon. If you give it at the beginning of the colon, you give a very flaccid colon, then you will get looping. You'll get less discomfort because the bowel will actually be able to be stretched, but I think you've got more risk of complications. If you're going to use Buscopan, it's on withdrawal only, in my opinion, except if you've got a very tight sigmoid colon. And then I would only, if it was Buscopan, I would only be giving 10 milligrams, not 20 milligrams. Enough so that it wears off, so then once I've got past the sigmoid. If you're going to ask me which is the most difficult, and my friend here is thinking colonoscopy, wow. The most difficult procedure in endoscopy is not ERCP, is not EUS, is not gastroscopy. Gastroscopy, by the way, I believe is the most neglected. Everybody treats it with contempt. So I think that should be taught on a course individually as a group like this. I really do. It's a bugbear of mine. I really do think it should. And not colonoscopy. The most difficult procedure to do is sigmoidoscopy. For a couple of reasons. We trivialise it a little bit by saying you don't need sedation. That's not a get at you. I was there too. I think that sigmoidoscopy, because you're introducing the scope and you believe you're not passing it very far, we just think it's a very quick test and off we go. It's not. To do sigmoidoscopy well requires you to negotiate the most difficult part in colonoscopy. Remember what I said, you can't live in the penthouse if you haven't got a basement. The basement is the sigmoid. All problems arise mostly from difficulties in the sigmoid. And if you don't correct the problems in the sigmoid initially, you will have issues all the way through. Once you've corrected them, the next few issues is just further on, then smaller issues compared to the issues you would have if you don't negotiate the sigmoid correctly. So people will teach you a different technique for flexible sig to colonoscopy. This is what you must do for colonoscopy. But in flexi-sig, it's okay to do this. It's not. If you start your flexible sigmoidoscopy as if you were going to do a colonoscopy, colonoscopy is easy. Get your foundation right. That's not a get at you, it's just what I believe. So anybody who comes to me to do flexible sigmoidoscopy, I actually say, right, I'm going to teach you colonoscopy. So they, oh, so then they'll continue, then I'll stop them. Say, right, fine. Then they get frustrated. I say, why are you upset? Well, I could have easily done that. I say, yeah, you could, but you wanted to do flexible sigmoidoscopy. Take ownership. So now I throw it back to them. What is it you actually really want? What your desire is to be able to do something really well. If you get your foundations right, you will do it really well. Safety. So what I want you to do, I'm not really going to go into and be rude to you by going through individual complications, perforation, all these type of things. pain, all that type of stuff, issues about bleeding, issues if we come across polyps. You should know that. You're senior people. You should know what the complications are in colonoscopy. If you don't, then that's a shame on you, not shame on me. All right. What I want you to do is have a think about what we've said, or what I've said, and if you want to talk individually about it, no issues. But remember the take-home message. The take-home message is use this first, your eyes first, your ears, your mouth. That is what you need to be doing. The machines are here to assist. Listen to these guys, the tech guys. They're there to help you. You've got a resource on tap straight away. The course is not just about you sitting there going, right, what's next on the program, right? Take ownership of your learning. I've already asked you to take ownership. What is that doing? Take ownership. So you'd set your own aims and objectives. Ownership of your learning. Come, ask. I think I need this. Is that okay? Anything you want to discuss? You're very quiet. Everyone looks at Sajda. She's beautiful, I know. But anybody want to ask Paul?
So if we have given sedation to a patient, then we can't use our ears to assess the patients. And
Why? Are you saying now the patient's now unresponsive? You give too much.
Given deep sedation, so we can't.
Deep sedation. What's the difference between deep sedation and an anaesthetic? You see, I can be difficult, I know.
Like propofol.
Okay. I understand what you're saying. What you've got there is your tech aide who is actually watching the patient. A patient can have deep sedation, so you've done that so that they don't. Your intention is that they don't feel anything. Then we've got REM. The patient has got their eyes shut. The tech guy will say, "He's just flinched, sir." We're using our ears. So if you intentionally are going to sedate a patient heavily, right, you're putting the patient at risk of that sedation after the test, so you must have very good recovery area, very good people who are observing that patient all the time. Commonly, the issues come 2 hours after a procedure, up to 6 hours. Okay, that's commonly in the UK where issues occur. People can get up out of bed, get dressed, fall over. That's a problem. That's a consequence of giving too much sedation. Patient broke a hip who got up out of bed. This is in the UK, quite easy. She had sedation. Nurse thought she was okay. There's only 1 milligram of sedation. She was 72, fit 72-year-old, got out of bed, felt woozy, fell over. Now some people could say it's because she had a flexi-sig, but it was related to sedation. She broke a hip, got a chest infection, passed away 3 weeks later. So think about what you're doing and why you're doing it. If you feel that you need to give that amount of sedation, what is the reason you're giving it? If you're giving it because they're a young lady, I've got a lot of forgiveness. If you're giving it because you normally cause discomfort and you're trying to cover it up, then you've got no forgiveness. The idea of the course is to turn around to you and say, look, what are you doing that could make you look at giving a little bit less sedation in most of your cases, and when you do give more sedation, you're giving it for a good reason, and then you can defend that reason rather than saying I give it to all my patients, which is not a good reason, because then you're treating every patient like you would do if you went to look at a car in a car wash. Every car gets this. Not all people are the same. They're not all cars. They're not the same. They don't drive the same. They don't behave the same. So now you're looking at them as an individual. So from what I'm trying to get you to do is, I believe that what we try to do a lot of the time is put people in a box, and we'll just try, this is how we're going to do it. Safety. Okay? That's not telling you off, it's just who I am. Okay. Any other questions? Yes.
And second is, which type of sedative and what should be the safest dosage of these sedative drugs?
See, I look at Sajda. No,
And what is the safest dose that you can administer?
nothing.
No need of any sedation.
78% of my procedures are due without sedation or pain relief. 78.
78% procedures consensual and कोई sedation नहीं.
So the
I've
rest
done
of
100,000.
22% of the patient which need sedation.
22, yeah?
Yeah. So how is that selected for sedation? Which type of patient we give sedation?
Midazolam, and I'll give between 0.5 milligrams to 3 milligrams maximum, and it'll be one in a year that I will give 3 milligrams.
0.5 से 3 milligrams लेते हैं और बहुत कम ऐसा होता है कि ज़्यादा.
And how do I know these?
कौन-कौन से मरीज को देंगे? ये
Okay, so
treatment.
it's asking you which patients do you give sedation to? What are your indications for giving sedation?
I can't say it in English. So what I give it to is that if the patient's nervous. When I give higher sedation, I would normally give a GA with somebody who's been sexually assaulted, abused. So I'll be looking to give a GA, without a doubt. Anybody who's got concerns with regards to that effect, then I would give it child abuse, etc. So those people, without a doubt, I don't want to know a thing. Okay, so that's a GA. So I'll book that, and that'll be done within 2 weeks. If I'm looking at a higher dose, it depends on the person that comes into the room. If I'm doing, you're thinking, if I'm, say I'm doing a therapeutic procedure, I'll use less air, but I get the patient to do more for me in moving around and stuff like this. 3 milligrams will be given for a patient who is exceedingly nervous. 2 milligrams. Now, I don't give it the same way as you guys. You guys will be administered slowly, okay? That's the correct way. Absolute spot on. You'll never get me telling you off in any way, shape or form. I give it as a bolus. Now, bolus can cause issues very quickly. I give 2 milligrams. You give it as a, I'm not asking you to do this. I wouldn't advise you to do this. When you get better, you can do this. But if you give it as a bolus, the blood transmission of the dose goes across is actually twice that if you titrate. So what you get is you get double the dose. So 2 milligrams equates to 4 milligrams across the blood-brain barrier, right? What happens is in that, the effect lasts a little bit less time. So your half-life is less because you're giving it as a bolus rather than titrating. And so therefore, the key to success in that issue, you've enhanced the effect of the sedation. And I'm saying this, I'm saying it quite open to you and honesty, but you have to be reasonably quick. So get into the cecum, you've got to get there in 3 to 5 minutes. If you take longer than 15 minutes, you're out of time. Then they know what's going on. So but that's when you get better. You'll find techniques for yourself that work. Now, I don't do that in all cases. That's in some cases where, because of post-sedation issues, while they're in the room, if you give it as a large dose, you've got them on monitoring, you're constantly observed because of the support that's in the room, and therefore you can actually manage issues. And nobody has ever suffered any issues with regards breathing, compromise, dropping blood pressure, etc. I'm not saying for you to do it. You ask me a question, I'll tell you the honest truth. And I'll tell you my reasons why. I won't hide behind anything. No need. Anything else you want to discuss? So we talked about sedation, we talked about safety, we talked briefly about... I'm not going to tell you how to take a consent. I agree with you that people could take the consent outside the room, not an issue. When they come in, you re-clarify that consent. You should countersign the consent. If you don't countersign the consent, that is a major issue. There are key performance indicators. There are things that we audit. One, and they do here. Are consent signed and valid, dated correctly? Is everything legible? Have you countersigned it? If you haven't, that consent is not valid. Afterwards, you've got all these issues with sedation given, yep. Cannula placed, yep. So those things will be all audited. The next things are KPIs. What is a KPI? Key performance indicators. Okay, tell me I'll let you say one. What's a key performance? Tell me a key performance indicator in colonoscopy. No, tell me what is what.
Give us the example of one.
No, they don't actually include the. Sorry? Complications. Okay. Okay. No, I've asked you for one. Key performance indicator.
Colonoscopy, can you get
No complication or adverse event.
He said that.
Comfort of the patient.
Comfort. Okay. Time duration. Okay, I'll let you have that. You're very quiet.
Complete the procedure with the proper diagnosis.
Oh. Right. So we're giving the answer for the entire thing. Be specific. A key performance indicator. Incorrect findings. Ooh. That's an honest man. Let me. Yeah. So cecal intubation rate. He said cecal intubation rate. Tell me another one. Oh, you get away with that. Tell me one. Sorry? Safety of the patient. Okay. Okay. The only one that I will accept in all of those is possibly the adenoma detection rate. All the rest are not. To reach the cecum, that's not a key performance indicator. That just means you've reached the cecum. Okay? It's that you've got to journey's end. The adenoma detection rate is how good are you at detecting what you're meant to be doing. Now, what assists you in reaching a key performance indicator like adenoma detection rate is reaching the cecum, is getting to the terminal ileum. So those are not key performance indicators. Those are just things that enable you to achieve what you need to do. What you were saying, they're too nebulous, too large. They're not an indicator of performance. Okay? So time to get to the cecum is nothing. Quickest time I've taken to get to the cecum. I'm going to tell you something in a moment, the reason why I can quote all this. How long, the quickest time do you think it's taken me to get to the cecum? 1 minute? How many? Okay, I'll fall asleep by that time. 4 minutes? Okay. Right, I'm going to be very facetious. I'm going to turn around to you and I'm going to say to you the quickest I've ever done it is in 2 seconds. Right? That's because they didn't have a colon. Right, man, that's a key performance indicator. So do you see where I'm saying terminal out straight? So it's not a key performance indicator of colonoscopy. In real terms, it's 17 seconds. That's 17 seconds to get to the cecum. Now that was how we used to do it. I'm sure you'll remember 17 years ago, 20 years ago, it was about getting in and getting out. I could do an entire colonoscopy in 3 minutes. Entire. Cecum. Picture, out. Because all we were interested in was tumour. Have they got a cancer? In, out. That's all we were interested in. It's only been a drive, a change in the last 20 years that we're actually looking at adenoma detection rate. What the future of the patient is when we've found small polyps. Are they worse on the right side? What's the data around that? It's only because we've started to get interested in that. So in reaching the cecum, it's important. But actually doing a correct examination is more important. I had to learn that because my focus was to exclude cancer. So your attention is to exclude anything bigger than 10 millimetre. It didn't count. Oh, it's only 10 millimetre, it didn't matter. Now we know anything less than 6 millimetre, the chance of adenoma is low. Anything above is high. Anything above 10 millimetre, oh, now we're talking How many patients have I left with larger polyps way back when I started, because that was the thread of thinking then. So again, we come back to me being honest to you, and I expect you to be honest to me. So in honesty, I'm saying to you, my practice has changed, had to change, because I'm willing to listen to the data and the information that's being given. Otherwise, I wouldn't have learned, and otherwise I wouldn't have improved. The reason why you're here, this is a foundation, so you can live in the penthouse. So we need you to actually start thinking about what is most important to me. Getting it right. So, anything else we need to go through? Anything?
Any problems that you normally face in your colonoscopies that you would like all to clarify? Or any skill acquisition?
I always a problem in the depressive mind. I always do in the depressive mind. I can't.
Okay. When we go on the mannequin, we'll talk about it, because it's better to see what the scope is actually doing. How many people have actually played with a scope? How many of you have actually stood there and played with a scope? You have. How many people have actually looked at it and understood what it completely does? Okay, what I'm trying to say is, when you've got the scope, when you pull the big wheel back, what happens to the image on the screen? So I pull the big wheel back, so it goes up. Big wheel forward, the tip goes down. Big wheel back, the tip comes up. I'm drawing it back. I'm drawing it back. Big wheel forward, I'm pushing it forward. Yeah? So when I pull, what happens to the screen? It goes up the screen. What does that mean? Now, you said you played with the scope. Now I'll put you on the spot. No, it goes up. Yeah. Yeah. No, it goes up. Okay. What he's thinking, and he's quite right, because what happens is when you pull the big wheel back, the electronics, you've got a processor and you've got a light source on the machines. Now, some machines now have got it incorporated, so it's just one. So you've got two machines, one processor, one light source. The light you see coming out of the scope, I'll go through this, but I don't really... the light you see coming out of the scope isn't what you actually think it is. But when you pull the big wheel back, if the scope is advanced, the tip will come up. I'll show you outside, and then it'll go up on the screen. If you rotate it 180 degrees, because of the processor, when I pull the big wheel back, and the tip goes down, the image still goes up. So what you're actually doing is you're actually thinking to yourself, oh, how do I know now, when the tip goes up, that it's actually going up or it's actually going down? Now you're confused. Yes, but you were insistent that it was always going down. Yeah. So what happens is that I like to know, this is important for when you're actually trying to do loops and negotiate pens. So when I come along, when I get the tip and it's coming back, if I was to scope, you'll see me do this. So when I put a slight clockwise torque on, it shows which way the scope goes. So when you do this, it shows which way the scope goes, and anti-clockwise. When I've got the tip down, and I do clockwise, it goes to the left. But they both look exactly the same, so when I actually pull the tip up, if it went to the left, I know the scope in reality is pointing down. That then enables me to look at the patient. If they're in the left lateral, I now know I'm pointing down, especially when I'm going in through the sigmoid. So that's why that helps you to actually think about how the bend is going and how things are forming. when the tip goes down and the tip comes up. How many people use the little wheel? Yep, 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 yep. I use it very rare. Very rare. I use it when do you use it most? Two places. Yep. Splenic flexion. You said reflection, didn't you? Nope. No. 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 You use the little wheel in diverticular disease an awful lot where you just tip it. So it just takes the tip just a little bit deviation. Retroflexion. What happens when you use the little wheel in retroflexion? So this suddenly becomes this. What's the second place you use it most commonly? TI intubations. So you're all thinking he's trying to trick me. I'm not trying to trick you. You know, any question I ask you, you already know the answer. Don't be frightened of saying the answer. I'm not going to make you look silly. You know, just because when you say something, I say no. I'm not trying to make you look silly. You know, just think about why you would use it. Sigmoid with diverticular disease, yes, it helps you steer a little bit more. Sigmoid diverticular disease, a lot of people want to give a little bit more air. Think about what diverticular disease, when I first came here, didn't see any. I actually thought, whoa, it's dead easy to scope over here. The scope just drops round, and it does, it just drops round. Now you've got diverticular disease. Why do you think there's a change in 10, 12 years? I know you know the answer. I know you know it. Yep. So increased travel. People are now looking at, so you know the answer. There's no question that you don't know the answer. You're just a little bit reluctant in answering. Don't be. No, you're not going to. I'm not going to embarrass you. You know, if you don't answer the question, I might ask the tech guy the same question, then he's going to answer it, and then you'll go, well, I knew that, and I'll turn around and go, well, why didn't you answer it? And that's just, and the two reasons why I'll do that. One, if you don't answer it, I'll ask them, and they'll know the answer, and that's because I want you to know that how respectful I am of the tech guys and the nurses in this unit. That they do know what they're talking about, they do know what they're doing. If you notice, I keep coming back to the same core principles. 1, look at the patient. 2, listen to the patient. 3, talk to the patient with respect, etc. Next, listen to the tech guy. But these are the people who are going to look after you. These are the people who are going to support you in what you're doing. Just think about it. So when we talk about I could list all the complications up on here. And then you'll sit there and you'll go, yeah, I've heard this before. He's confirming everything I've heard before. Right. Well, I'm not about to do that. What I'm going to do and turn around to you, your safety net. Your safety net is your eyes, your ears, your nose helps you. Honestly. If something don't smell right, it ain't right. If somebody puts something in front of you to eat and it doesn't smell right, are you going to eat it? No. The tech guys are going to keep you safe. That's if you get good ones. So it's very important. So I don't want to insult you by going through individual complications. Yes, this can be caused. Yes, this can be caused. Yes, because you're not junior doctors. You're senior people doing a very important job. And if you don't know it, then it's your responsibility to take ownership and get to know it. Because during the next 3 days I will be testing you anyway, and then I'll say to you, why didn't you ask when you had the opportunity? That's what I'm like. I'm sorry, anyway, I've waffled on.